Well, good evening and good morning to some of you. Welcome to today's live from Cleveland Clinic broadcast on a topic that's very near and dear to my heart, chronic gastrointestinal diseases, managing the transition from pediatrics to adult care. I want to thank you to over the 500 healthcare providers who registered today for the event across the globe representing 60 countries. We really want this to be an interactive process, so please do interact via the chat box. Give us your questions and we'll try and answer them during the discussion or on the chat box itself. We want to thank our corporate sponsors for their generosity in providing educational grants for our 2025 series. We could not hold these CME offerings without our industry sponsors, and we're most grateful for the support from Cook Medical LLC, Janssen Biotech Incorporated, Medtronic, Olympus Corporation of the Americas. So I'd like to introduce our faculty. My name is Jessica Philpott. I'm an IBD provider and I spend a lot of time providing transfer care from patients transferring from pediatrics to adult. I'd like to introduce my co-moderator, Claire Beveridge. She's one of my colleagues in the Department of Gastroenterology, Hepatology, and Nutrition, a specialist in EOE, and assistant professor of medicine. I'd also like to thank our Cleveland Clinic faculty that are joining us today. I'm excited to hear your input on this topic. Jacob Kurowski from our Pediatric Gastroenterology, Pediatric Hepatology and Nutrition at Cleveland Clinic, Assistant Professor of Pediatrics. Stephen Lupe, one of our gastrointestinal psychologists and the director of our behavioral medicine in the Department of Gastroenterology. And Daphne Spiropoulos, another one of our great gastrointestinal psychologists from the Department of Gastroenterology. So welcome, team. And we'll kick off with a talk from our colleague Jacob Kurowski on IBD transition, the pediatric perspective. So welcome, Jacob.
All right, so we're going to talk a little bit about transition in general, and then specifically what I deal with a transition of IBD before we hear from Dr. Beveridge on the EOE side of things. So we'll talk what is transition and transfer of care, what is currently being practiced as far as transition goes, some of the barriers that we find in transition, and ways to kind of stimulate the transition overall. All right. So just as our definitions go, we want to remember that transitional care is the planned movement from pediatric-centered care to the adult system. Health really transitions from guardian to patient, while a patient transfers from a pediatric to an adult provider. So we always call it transitional care. We have to make sure that when we're talking to patients that we kind of define that a lot of the responsibilities need to transition far before the patient ever actually transfers to an adult gastroenterologist or whatever specialty they're in. And this definitely requires a lot of preparation by the patient, by the guardian or parent, and then both by the pediatric provider and the adult provider. And so as part of basics, the American Academy of Pediatrics, which has a lot of great resources on transition, has a transition core elements policy, which they recommend that each institution, pediatrics and jointly with adults, have some type of planned momentum to get patients over, which includes a transition policy, some way of tracking and monitoring your transitions, assessing readiness, the planning, the actual transfer of care, and then a way to circle back for completion, which kind of gets a little bit back to our tracking and monitoring. So when looking at the actual transition programs that are out, the most commonly recommended mode of transfer is some type of joint peds adult GI clinic. But in a survey done a number of years ago of pediatric gastroenterologists, the transfer of care was actually done via phone or email almost 60% of the time, and then a joint clinic only happened about 20% of the time. There are a lot of physical barriers that goes along with it. And then other aspects that are important to the transition program or clinic, outside of just the actual physicians themselves, are having a care coordinator or some type of social worker, a mental health expert, nutrition, particularly if there's been issues with malnutrition. And then oftentimes we'll have some type of either workshop or paper internet-based educational program, but something to educate the patient along the way on the transition of responsibility. So in a recently published systematic review of transition programs, they looked at 21 studies that looked at the process of transition, and out of those 21, 20 of them had a joint peds adult clinic. So the people that are studying it are trying to model or emulate what we think is the ideal situation when you have both the pediatric and adult GI doctor in the room. And then they examine the transition programs really more in a pre and post outcomes, so that the patients are serving as their own controls. And then in that systematic review, they also looked at transition-related intervention. There were 8 studies there, and there was a lot of heterogeneity. So some of these visits included an IBD nurse visit ahead of time as part of the education. Some programs have developed educational models, and then other interventions like problem-based solving, web-based education. There's even been some transition workshops that have been done, and even a virtual transition workshop. And so within all of these models, you'll find that in ways to assess patients where they're at on their transition journey, you'll find the 2 most common tools are IBD yourself and transition readiness assessment questionnaire or tract. The IBD yourself is specific to IBD patients in general, and we'll ask IBD disease specific entities, whereas the tract is generalized. It's not necessarily specific to IBD. It can be used across any disease process, and so you can compare from one to the other. There is, again, like I said, a lot of heterogeneity between these studies, but if you looked at the systematic review, that there was significant improvement in all key transition-related outcomes, including knowledge, self-efficacy, adherence, clinical attendance, and readiness, regardless of the intervention. So putting a little bit of that time in and just focusing on the process of transition in and of itself may be enough to stimulate a patient. And just to give you an example of that, one of these articles, which I thought was this study was really well done, they looked at outcomes before and after a transition in the UK, plus or minus 2 years, and they looked at patients who either went through a transition clinic versus no transition clinic. And statistically significant in all values is that patients who went through the transition clinic at 2 years after transfer, had higher rates of medication adherence, had fewer missed clinics, had fewer surgeries, had fewer hospitalizations, and had higher TNF usage, almost 2-fold in all the categories. So some type of transition clinic is really important. So thinking about what are the barriers to transition. So there was a survey done, again, several years ago, that looked at the focus groups of the patients, the parents, along with the providers, and they identified 4 major themes that prevented patients or were barriers to patients transitioning. Okay, and so those 4 major themes were that there was a concern by the patient and the family that they might receive poor quality care in the adult setting, that there was a lot of high parental involvement was a barrier to the youth developing self-management, a lot of concerns around finances and insurance, and then the loss of valued relationships with the pediatric providers. Now, when they looked at, they did a separate survey of just physicians of our National Pediatric GI Organization and the Crohn's and Colitis Foundation database, where they searched and asked them questions, not in a group format, but just an online survey. And you'll see that some of the biggest themes are that providers identified that either patients are reluctant to transfer, the parent is reluctant to transfer, and the provider is reluctant to transfer. So everybody is really invested to some degree or another, and giving up that relationship is an issue. And so we have to prepare ourselves, maybe not just the patients, but maybe ourselves as the physician as well, that patients need to move on. And yes, that is, a relationship you may have had for a long time, but inevitably every patient has to go from a pediatric to adult provider at some point. So a lot of what's been looked at is age as a predictor of transition, but is it really age? What is it about age? Is age really linked to maturity? Maturity, how do you identify maturity? So I mentioned earlier, there's the tract questionnaire, and I think this is one of the easiest tools. And I'm not, there are many, many other tools. This just happens to be what we use. And it is a tool. It is 20 items, 5 vector structures, and it can be used over and over again throughout a patient's journey from pediatrics to adult care. The initial track is 29 questions that was developed from 192 adolescents. And it's, again, not IBD specific, but it has really good reliability, and it's been used as a gold standard. So the whole idea, though, behind the track is the trans-theoretical model for change. So if somebody's going to decide that they really want to make a change in their life, they go into these phases of pre-contemplation, contemplation, determination, action, relapse, and maintenance. Okay, and this questionnaire itself is set up on these phases in the model for change, meaning that if they ask somebody, are you able to call your provider's office or answer questions in a visit? You know, a patient might answer, I don't need to do this. I don't know, but I want to learn. I'm learning to do this, and so on, or I've always done this. So when you look at clinical practice, another survey of 195 patients, anywhere from 16 to 25 years old, they took the tract questionnaire. The goal was mastery, was to get mastery of 18 of the 20 tract questions. So when they did this, only 5.5% actually met a goal of getting 5 out of 5 on 18 out of the 20 questions. But higher tract scores were associated with older age and female gender, but there was no association with time since diagnosis. Okay, and so age does, in a number of studies, not every study, but more often than not, drives transition readiness. And age, frontal lobe development, we might hear some of that later, really go hand in hand with readiness for transition. So the care, whereas the care in the setting were not. So what we do at Cleveland Clinic is, as part of our assessment, when Dr. Philpott and I run a joint pediatric adult IBD transfer of care clinic. And so when we're assessing the patient, either even before the visit, which means we might be talking with the patient or parents, hopefully more the patient than anything. Maybe we're talking a lot of the nurses who know the patient as well, whether it's my patient or another colleague's patient. We want to get an idea of what is the parental involvement. Are the parents making the decisions, or has the patient become more independent of the family? Are they there at the visit by themselves? Are they allowing the parents to be there, but then answer the questions on their own? It's not just being there by themselves. It's even if they're not by themselves, they can decide who's in the room and how they're answering the questions. And if they need to, the family exits. How engaged is the patient in the clinic? How much do they participate in the clinic? Are they adherents? Do they have issues with adherence to medications, showing up for infusions? And then socioeconomic challenges. So job stability, where are we in college? Are we after college? Maybe we might be facing a pregnancy. Is there a concern for substance abuse or some other life situation that might make it a little bit more difficult through this transfer period? We don't want to transfer somebody when they're having a medical crisis or some type of mental health crisis. That is not our goal, but so those are things that we want to know about, especially if there are chronic issues, so that we can be prepared. And maybe we're going to have a conversation with our psychologist, and the psychologists are going to do a handoff, or so on and so forth. And then do they have, especially certainly have patients who have intellectual disabilities or other comorbidities where there might be other subspecialties involved with their care that we need to get involved. So we published an opinion review paper a number of years ago and kind of put together what we thought was an ideal model for transition of responsibility and transfer of care. I've gone over most of these points already, but a lot of it focuses on education and then doing an assessment of the patient, making sure that we're addressing all those issues, and then working on the transition clinic and then making sure they're doing well post-transition. All right. And then suggestions to improve transition of responsibility, as I kind of mentioned, you need to separate the parents and the patients during the clinic visits. And this was identified from some of the surveys that were done that I mentioned earlier. One of the other big issues is you have to hold the adolescents, young adults accountable for their care. So if if they don't show up for a visit and you still have to call the parents to find out what they're doing, or you can't get hold of the patient, clearly that's not a patient who's ready for that transfer of care. And depending on their age, maybe a little bit more emphasis on their education and motivation. And then one of the main things was, like, sometimes the parents have to know that it's like how to let go, which is not the easiest thing to construct, but it might be able to push a little bit there, or encourage that movement of the independence, especially if the patient, the young adult, is characteristic. The comments is a transition, during college or after college. So in general, we will transition patients between 22 to 24 years old when they're out of college, especially considering that college might be in a different location. I hate to transfer a patient in one city, then they graduate college, and then have to transfer care again when they get a job somewhere else. So a lot of it depends on what is their situation, whether they're going to go on to work full time, or they're going to go to college and then go on to work full time. What is their situation? We want to make sure that they are a fully independent, or as independent as possible, young adult, so that they can manage their own care, so that when we're transferring that care, we're really setting them up for success. So just as a reminder, transition of responsibilities, it could be optional, but transfer of care is not. So be the labor great or small, do it well or not at all. Thank you.
Well, thank you, Dr. Karowski. That was a great summary of some of the most important aspects of transferring both responsibility and care. Now I'm excited to hear from my co-moderator, Dr. Beveridge, and she'll explain the adult perspective on transfer of care for EOE.
Thank you so much for that introduction. Let me share my slides. So just as Dr. Philpott was saying, I'm going to be discussing EOE. So I'm an adult gastroenterologist, and I have a pediatric GI counterpart as well. And we work on transitioning our EOE patients from the pediatric to adult side. Here are my disclosures. So Dr. Karowski gave a wonderful overview of what we need to do for transition of care in general, as well as giving some nice specifics for IBD. So I'm not going to reiterate a lot of the general things in terms of barriers and issues. I'm just going to focus in on EOE specifically. So in terms of eosinophilic esophagitis, it is a relatively new disease compared with IBD and some other chronic conditions that can happen for pediatric to adult patients. So there is limited data for this, but for what we do have, we have seen that when there is no formalized transition of care, unfortunately, we can lose follow-up for up to 16% of patients. And there can also be a big delay between their clinic visits from the pediatric to adult side and for their endoscopies from the pediatric to adult side. So, nearly a year, and then for the endoscopy, 730 days. So that's a huge delay. And we also see that there can be a higher medication non-adherence rate for patients who may have transitioned to an adult gastroenterologist compared with staying with their continuity, their pediatric gastroenterologist. So just as Dr. Karowski was saying, there can be all of these, issues and delays when you're transferring, and you got to really make sure that your patients are ready for that transition. The other thing that we see is there can be a significant deficit in the healthcare transition knowledge, and that the readiness scores can be much lower in EOE compared with other chronic health conditions. And again, I think a lot of this has to do with the fact that it's, somewhat a newer disease state, and we're kind of catching up, and we are getting a lot of data and information from our colleagues in IBD, hepatology, transplant, to really be able to set our patients up for success. So some of the EOE specific barriers barriers can be an elimination diet, but even if a patient isn't doing an elimination diet, some patients can just have persistent concerns or issues regarding food. So maybe it's a food allergy. We know that that's a common associated condition. We also see a lot of food hesitancy. So if someone has had an issue with swallowing for a long time, if they have a history of a food impaction, they can get really worried and nervous about eating. So some of the biggest struggles that patients have reported for EOE, up to 40%, were regarding planning meals, shopping for the right food, cooking and finding the right foods in cafeterias. And since a lot of this had to do with transition, a lot of this has to do with like dining halls, like going to college, and being out of their usual home environment. In terms of the medical aspects, the biggest struggle that patients had reported, over 20%, was lacking knowledge in terms of their insurance coverage. And what their copays are going to be and how to manage all of that. The other thing that we can see from the physician practitioner side is in regards to difference in practice patterns. So this was a study that was done in Israel, comparing pediatric gastroenterologists and adult gastroenterologists and how they manage their EOE patients. So this graph here is showing that when patients were offered, they called it an EOE specific therapy. It's basically, if it's an older study, so if they weren't responsive to PPI, although now we know that there isn't PPI responsive, it's all EOE, and PPI is just one of the therapy options. But in terms of this study, there's a big difference between adult and pediatric gastroenterologists in terms of what therapy they're going to recommend. So there's a bigger push for the pediatric patients for them to do an elimination diet versus for the adult patients to be on topical corticosteroids. So you can imagine that then when you're transitioning a patient from the pediatric to adult side, if there's this big difference in terms of what's recommended by your physician, that could cause some confusion and some issues when you transfer. I don't have the graph on here, but the other thing that was a big difference was in terms of follow-up endoscopies. So for the pediatric side, they were just kind of scheduled for follow-up to assess for response to therapy, and then kind of scheduled for, repeated ones after that to make sure that they were still in remission. And on the adult side, it was a little bit more based on symptoms. So again, that can be a point of confusion or issue for a patient if they're used to one practice pattern and then they're being transitioned to a different practice pattern. So very similar to what Dr. Karowski was showing, that he and Dr. Philpott do for the IBD. This is very, very similar to what they created. And I am sure that the EOE folks took a lot of inspiration from them in terms of creating what they recommend as a transition of care for EOE patients. And so, having patients early on, in their adolescent, teenage years, really start to, not necessarily talking about the transition, but developing that independence, just as Dr. Karowski was saying. And then as they get older, to then start discussing more seriously, how they're going to transition, assess their readiness, what things they need to improve on before a transition can occur, and then identify whoever their adult care practitioner will be, and make sure that that person has really reviewed all of the records and that there can be this joint visit, whether it's, through gastroenterology or allergy, because, either specialty can manage EOE. So I want to talk a little bit about what we do in the Cleveland Clinic transition. So when I joined nearly 4 years ago, Dr. Patel and I started this EOE clinic here. And what we do is, Dr. Patel leading up to it. She's our wonderful pediatric gastroenterologist who focuses on EOE. She'll kind of assess if she thinks the patient is starting to get ready for it, and she'll help them start to get independent and ready for it. And then when we think that they are, then we start to do a joint visit. So I'm going to discuss a little bit in more details about our joint visit as opposed to like the before and after. So during the joint visit, Dr. Patel already has the relationship with the patient. So she's the one who leads the clinic visit. The patient knows that I am there, that I'm going to be the transition person and who they're going to see going forward. But Dr. Patel is going to be the one who leads it. And then by the end of the visit, then, I get to talk with them a little bit more and be able to give them an idea of what the adult side looks like. But essentially the most important thing of that visit is for them to feel confident that I have heard, what their care has been leading up to this point with their pediatric gastroenterologist, and to be able to meet me so I'm not a new face for them, and feel confident that we can go forward with, whatever pathway we want to do. So some things that we really discussed during that visit is, what therapy are they currently on? Is it working for them in terms of their histologic remission, their symptoms, any side effects? And if it's not, what therapy are we going to go to next? But even if it is, to just kind of discuss, is this going to work for you as you're transitioning? Because a lot of these patients are going to be going to college or are already in college. And so that can be a difficult time for patients who are doing a diet elimination in terms of being able to control what their diet is. And so during that period of time, a patient may decide that they want to do a medication instead. And then similarly, we talk a lot about, I'm able to do a lot of televisits with them in terms of continuity, but then in terms of coming back, if they are in college, I make sure that I know what their spring break, summer break schedule is so that we can fit it in during that time. And then, since one of the biggest issues for EOE patients is about insurance and coverage, we make sure that we discuss that to make sure that they understand what their coverage is. Are they going to be staying on their parents' plan through the age of 26? Or are they going to have to change to something else? And then this is talked a lot about in the EOE literature, but making sure that, whoever you're doing a joint clinic with, that your practice patterns align. So Dr. Patel and I have very similar practice patterns in terms of, how we counsel patients, in terms of how we discuss therapies, what we do in terms of endoscopies. So that helps a lot for patients in terms of feeling like things are very similar. One issue that we were having a lot was being able to identify the patients. And this is a barrier that's discussed a lot in the literature as well, that, ideally when you have a transition clinic, that you have a coordinator who can really help guide patients through it. But, that's not always a realistic resource at every place. So one thing that we have used is to be able to use our electronic medical record to help identify these patients, so that we can, reach out to them and make sure that we know who they are, make sure that they haven't, fallen through the gaps between the transition, and make sure that Dr. Patel and I can have this joint visit with them. And then, lastly, we really like to do these in person because I think that's nicer for the patient and often, the parents who are there with them. And we do strive to do that, but we are realizing that it doesn't work for every patient because of school, because of other reasons. They may not be able to come on the day that Dr. Patel and I are able to be there in person. So it's been nice to be able to use telehealth, telemedicine, to be able to give more flexibility for our patients to still allow for that joint discussion. So thank you. That's the end to my slides. And next, I want to introduce, very excited to have Dr. Lupe and Dr. Spiropoulos, who will be discussing the psychological aspects of transition of care.
Thank you, Dr. Beveridge. That was great. I think you're going to hear some like overlapping type stuff between Dr. Karowski, Dr. Beveridge, and then ourselves as well. So just so everybody's aware, we are two of the GI psychologists within the department. We have GI specialized psychologists that work with patients who have been diagnosed with GI conditions. In talking about the transition of care is one of the things we'll do. So Dr. Spiropoulos, do you want to go ahead and share your screen?
Sure, absolutely. Hi, everyone. Give me 1 second. There you go. Can you see it?
Yep, perfect.
Perfect.
So go ahead. So let's start talking about why we want to talk about this. And I like that we're following what Dr. Beveridge was even saying. She put a lot of emphasis on that, instilling choice and instilling, like, and Dr. Karowski did as well, instilling that agency over to the person who is making the transition from pediatrics to adult. I always think about this, you know, if we don't do that, it's kind of like you leave this wonderfully nice, comfortable world in pediatrics where the walls are painted bright a lot of times and stuff. You end up in these adult clinics, at least where we work, that are very white and very sterile, and we need to make sure that people are prepared for that. So why are we talking about this? We want to minimize disruptions in care during this time. That these people that are transitioning, there's a lot of things going on in their life as is, and getting them to pick up their care, take ownership of their care, and move into that adult world can be difficult. We want to interrupt any kind of disruptions in care. I know myself personally, I frequently see people will drop out right around 20, 22-ish, and then they show up later in like flare and IBD. And then the difficulties of living with IBD are further complicated by the fact that these people have not, because they are younger, do not have fully developed coping skills. And the psychosocial pressures that they're going on, it's a rough time to transition from being at a pediatric over to an adult. Next slide.
Sure. I'm trying to do, oh, hold on. There you go.
There you go.
Okay, so just continue on to what you were saying, Dr. Loop, about the psychosocial stressors associated with IBD in children and young adults. We know that when there's a pediatric onset of the disease can be and feel unpredictable to patients. Some patients may feel stigmatized, and the disease might also interfere with their development and social functioning. And then we know that the overall burden of IBD is affected and determined by symptom severity and then disease activity. So whether there's inflammation or not, among other factors. And then what we're trying to do as gastrointestinal psychologists is help reduce the disease burden for patients, which is greatly also affected by their ability to cope adequately with their symptoms. Moving on to the next slide. So some other psychosocial factors to consider are the feeling of shame that a lot of patients might experience because of fecal incontinence or other reasons, social anxiety that could be associated with school absences, challenges around what they can and cannot eat, frequent bathroom visits, whether there's a bathroom available near them as well. And then we also know that age, social support, and the degree of stress that adolescents experience will affect how they manage and react to their disease. We know that there's a significant psychological burden associated with IBD that influences both disease outcomes and patient identity. In terms of mental health, what we know about adolescents with IBD is that they are at greater risk for developing major depressive disorder than both the general population and, which I found really interesting, those with other chronic diseases. The rates of depression in adolescents with IBD are 25%, and there's a significant relationship between depression and anxiety and disease activity. So essentially how the disease manifests for every person. The relationship between IBD and mental illness is bidirectional, and it's unified by systemic inflammation that inflicts damage on the body's immune and nervous system. So when we say that the relationship is bidirectional, what we mean is that we all know that when we get anxious, for example, that might affect our GI symptoms. But what's new to the game, I guess, is that the condition of our gut also affects our emotions and other factors associated with brain activity. What's important to consider is that patients with IBD and depression or anxiety are less likely to adhere to standard medical care, which can greatly impact their outcomes as well. Dr. Loop?
So, one of the things that's kind of the take home, and this is hard. I mean, and then think about this, like trying to figure out how do we do this in like side of a medical clinic. Because I also agree, what Dr. Kurowski was saying, that you have to do like a readiness of change assessment. You have to be looking at where this person is developmentally, because we don't all advance at the same rate. And the data would show you that some people's frontal lobe is not fully myelinated until mid-20s, almost to early 30s. And they may not be capable of making complex decisions and may need a little more support with that. And that also then, if there is those complications, it's going to lead to more burden as far as anxiety and depression. And, the Crohn's and Colitis Foundation we put out a consensus statement in the adult world saying we should be screening everybody. And I would say the same thing for pediatrics. So this is, kind of one of those things that everybody that we talk about, that the more severe the symptoms are, and we showed this in data, even with mental health concerns, that it was close to the same looking at that and disease severity from standard symptom assessment, that about 15% of the patients with IBD accounted for roughly 50% of the healthcare costs. In many of those who had concomitant pain, depression, and poor social support, that those are things that we can work on that are leading to this overuse of care, going to the emergency room more often, being admitted more often. And that's one of the places that we really, really have some control. Next slide. So when should we start to do this? I think that the idea of transitioning should be introduced early. And so when they're young adults, even 18ish, start talking about that with your patient. Start having some of those conversations with the family and the patient. Make sure that they fully understand their disease. I'm going to get to this here in a minute, one of the bigger misunderstandings. But a lot of times patients show up and they don't fully understand their disease and their treatment plan. A lot of times patients will kind of come up. I mean, your brain doesn't want to believe you have a chronic disease. So it may come up even with the story of, I'm in remission. I've kind of beat Crohn's disease. I don't have to worry about that anymore. And patients really need to be educated about the need to stay in front of the disease, to stay in front of the, and we can extend this out to other GI conditions. We're just talking about IBD specifically. So that ability to gather information and self-advocate with healthcare providers that generally need some training. And that may go back to a little bit to that idea that we've already started to talk about, making sure that we're talking to the patients themselves, and not necessarily just mom and dad. Patients will have this bad habit of when they have a chronic disease, especially from a kiddo's age, like little kiddo's age, they kind of sit off to the back, and mom will step up or dad will step up or caregiver will step up and talk to the physician, talk to the care team. And we almost have to be watching for that, because then these adults show up and they don't know how to advocate for themselves, don't know how to talk to healthcare providers. And that training can start early if you're a pediatric gastroenterologist. So they should probably be in relatively stable health. That was already brought up, that in the middle of a flare of symptoms is probably not the time to start doing a transition, that we should probably get them in relatively stable health, if at all possible, before we start trying to transition them over. And then have sufficient self-efficacy and enthusiasm for active communication. So they need to be able to do that, and we need to talk about the importance. I do talk about that with patients, the importance of their ability to communicate with the treatment team. And that's very, very hard because a lot of these patients are also pushing back on medical trauma as well, that it can be traumatic for a kiddo to not have agency over their body when they're getting physical exams and stuff like that. And so it may be harder for them to communicate with the treatment team. I've seen this multiple times where patients will be like, I really don't want to because I don't want to end up in the hospital. I don't want to end up, and that's that medical trauma showing up. Next slide. So patients' priorities versus, this is where I was starting to get off on my tangent there before. Make sure you're speaking the same language as the patient. What a gastroenterologist a lot of times is talking about with remission is not necessarily what the patient is talking about. I see this all the time where patients will come in for a scope. They get scope, gastroenterologist comes out and goes, "You're in remission." And the patient goes, "What are you talking about? I'm still going to the bathroom 15 times a day," right? What a gastroenterologist is talking about as remission is, I don't see any sign of disease in your intestines. What the patient is talking about as far as remission is my physical symptoms I'm having. And so making sure you're kind of talking the same language and having those conversations about what we're talking about, even as part of this transition, is important. That's what the next slide, the next point is there, is that the physician's focused on clinical remission and avoiding surgery. And that's even helpful to talk to about patients. I've talked to patients about that. What your team, what your physician, what your nurse practitioners and stuff are all focused on is staying in front of this disease to the best of our ability to try to keep your intestines as healthy as we can for as long as we can. And watch the language we use there too. Notice I'm kind of breaking it down to like about a 5th grade level. So I want to make sure that they understand that. And that adolescents are really, really concerned with the social aspect of their functioning. That's what this stage of life is all about, is starting to build those relationships with peers, do these culturally appropriate, transition moments. In the US, we have like prom and stuff like that, and then fitting in with their peers.
Should I move on to the next slide, or?
Go ahead, yeah.
Okay. So essentially, we want to say that research shows that about 80% of adult gastroenterologists report that there's inadequate preparation of patients transferred from peds. But there are some suggested competencies and protective factors for children or young adults prior to transitioning. We've listed them here, but I'll go through them one by one just in the interest of time. If I figure out how to change this slide. So the first, hold on, I skipped one. Okay, so the first one is to develop a disease narrative. So when we talk about developing a disease narrative, we're talking about the patient's ability to explain IBD to others in social situations. And this also includes the boundaries that people have, because we might not feel comfortable, for example, sharing everything about our medical history with everyone, but there are some people that we might choose to share with. So then research shows that it's important that patients establish their own disease narrative and have it ready to go whenever prompted or whenever they feel like they want to share. Some questions that we might ask patients that might help them develop that disease narrative is, what is IBD and what symptoms are most prominent for you specifically day to day? What are some of the challenges that you might experience related to having IBD? Sometimes, for example, having to do with medications, medical procedures, dietary restrictions or activity restrictions. And then the last part is really important because it has a resiliency focus, which is, in what ways have you grown through the challenge of living with IBD? We always want to empower our patients as part of self-efficacy, especially in that developmental stage. And a way to empower them is to remind them that they've been navigating through a challenging health situation for a while, which can be helpful and a protective factor during the transition. Another point that might help with the transition is practicing gratitude by developing a gratitude practice. Some questions that patients might ask themselves are, what's something I'm grateful for today? Who is there in my life to help me cope with and manage my IBD? And who have I been able to share thoughts or ideas with regarding IBD? Then Dr. Loop already spoke about self-efficacy. So self-efficacy is the belief in our ability and capacity to act in ways necessary to reach specific goals. And it's really important for everyone's self-confidence throughout adulthood as well, not just for young adults or children. So ways to develop self-efficacy, one way is to invest time in the IBD community. So finding others that are struggling with the same disease, even though it manifests differently for different people, but so that patients feel less isolated. The ability to complete everyday tasks, for example, calling the doctor. I can't tell you the amount of times we hear the I'm too embarrassed to call and make an appointment for myself because my mom used to do this for me all the time. That's a self-efficacy task. And then another part of this is encouraging patients to be involved in their care and explore their specific patient goals and voice them throughout the session. So even what Dr. Luke just said about social situations and anxiety related to that, voicing that in a doctor's appointment can be really important for self-efficacy. Okay, and then setting SMART goals for disease management. This has to do with a deliberate transfer of disease management tasks that all of my colleagues have already spoken about, that was previously handled by caregivers to now the patients themselves. So in order to set a goal, I'll give you an example so that I make this easier. The goal needs to be specific. So let's say a patient has a goal of being able to administer a specific medication to themselves. So with that, we're answering what's the goal, where am I going to do it? So I'm going to do it at home, for example. And when will I work on this specific goal? I might say, we'll talk about the timeline later, but it could be something like a week from now, 2 weeks from now, a month from now. Then the goal needs to be measurable. So we need to make sure that there's a way to assess whether that goal was met. So, whether I administer the medication to myself or not is the way to measure that in this example. Is it achievable? If a patient has never handled taking medication before, are they able to do it on their own through the first try, or will they need to be supervised by their parent for the first few times that they try, and then they can realistically move on to doing it themselves? Then the goal has to be relevant to a larger goal. So a larger goal could be independence and being able to navigate life on one's own. So all the goals that we've been talking about in terms of self-administering the medication fall under this category. And then time sensitivity is the most important one. Dr. Loop knows this very well, and also gastrointestinal psychologists know about this, but patients will say, yeah, I'll do this in 5 years or something like that. It's really easy to postpone, progress in terms of that. So we need to keep our patients accountable. And then learn more about the gut-brain axis, specifically as it applies to the patient. So 2 questions that we usually ask is, what do you notice about how your stress levels influence your IBD symptoms? For example, if you're more anxious because of school or anything like that, do you notice that your GI symptoms are getting worse? And then when you begin to experience IBD symptoms, how does this impact your mental state? It could cause anxiety, which can happen also on a physical level, but it can also happen on a cognitive level. So a lot of us know that when something happens or we start feeling sick, we start the narrative in our heads of, oh, I'll never get better, this is horrible, and all of that, which can definitely affect patients' mental states. Dr. Luke,
So the last slide here, we'll kind of go through this and I'll just kind of brush on it. I just wanted to make sure there was a consensus statement that was put out by the Crohn's and Colitis Foundation. It was actually developed down in Australia and New Zealand in 2024 from a multidisciplinary group that included some GI psychologists. And I just kind of highlighted the highlights here, and they go along with what's already been talked about. Have a structured program, include a mental health screening, ask about things like depression, anxiety. Like I said in the comments, it's always good to have like a prep kit set up, including maybe a number of someone that you have talked to, a local counselor or something, maybe that you've set up a agreement with, so that you know what to do if it does start showing up and you can work collaboratively with it. Use of transition coordinators improve the outcome. So if someone is there, there's another touch point that helps, and at least one visit with both the adult and the pediatric GI is helpful, so that there is a transition over. What happens is trust kind of transitions over from one provider to another. So you can look this up. It was published, like I said, in Crohn's colitis, and that though that's a very helpful resource as well.
That's all from us. If anyone has any questions, please feel free to ask.
Thank you both so much for that talk. That was really, really helpful and illuminating. We're going to do a little bit of a Q&A now. So I'll ask all of the panelists to put their videos back on. And for anyone who's joining us, you can type into the chat box any questions that you may have. And if you want to, direct it to me, that's also fine. So I can start with a couple questions myself while we wait for some people to type in their questions. So Dr. Lupe and Dr. Spiropoulos, in terms of mental health, I mean, it's a great point that this is a stressful time for patients who are transitioning and including kind of a mental health screening. In the day and age of not having a lot of time during a clinic visit with your patients, where you're probably going to be focusing a lot on the medical aspects, and IBD, especially can be very complicated in terms of what's going on. What is kind of, how would you recommend and what kind of phrasing should we use in terms of screening for mental health? And then if it seems like, they really could use some resources, what would you recommend in terms of resources and support for patients?
Sure. So I know our practice specifically, we send out mental health screeners prior to the visits with us, and that is one way of doing it. And there you can use a PHQ-9, GAD-7, a HADS, whatever you have, promise measures even there. That is one way to do it. But it can be, we spend a lot of time actually debating this, how to assess this. And if we don't want to use these formalized questionnaires, I'm happy if a gastroenterologist even asks, hey, how's your mood been? Is this, do you find yourself worrying a lot about symptoms? Stuff like that. Anything you're doing that kind of hints at it, right? If you've got a kiddo who's like, no, which is kind of unusual, but if you have that, there's less of a need there. If mom and dad are not telling you there's a problem, caregiver are not telling a problem, that's kind of how I'd go about assessing it. As far as then I'm going to be quiet because I want Dr. Spiropoulos to chime in on this too. As far as like resources and whatnot. So I think there's going to be a bigger boom in this. The digital therapeutics are starting to get involved. They'll be available just because there is a shortage of mental health providers. Any support you can give people, any talking you can do about it is helpful. And a lot of the gastroenterologists are very, very comfortable with neuromodulators. So using what are traditionally called antidepressants, anti-anxiety medications for GI symptoms, there may be a double bang for a buck there. If someone's complaining of a lot of abdominal pain, you can use something like an SNRI, which may also help with anxiety as well. Same thing with like nausea and vomiting and Remron. So there's in the Rome Foundation is a great place to go look at. They have simple cards you can carry with you that kind of go over what symptoms you're seeing and which neuromodulators work with that. So those are some of my ideas there.
Yeah, and if I may jump in, I concur with everything. I just wanted to keep in mind that a lot of the participants come from different countries. And as a Greek person myself, I know that the resources that we have in the US are not necessarily always available to the rest of the world. So what I always encourage people to do, specifically when there isn't a GI psychologist available, is to try to find a mental health referral with someone who has training and experience working with chronic health conditions, which I think in the UK is called clinical health psychology as well. I know in Greece that's what it's called. I saw some neighbors on the map, but I think that's a way to navigate that. And then pointing at the resources that we do have in the US through the Rome Foundation, and then the American Board of Clinical Health Psychology might be helpful to our colleagues. Yeah.
Thank you. That's really helpful. And also, to add on to that, if your patients are transitioning and they're in college, oftentimes universities will have some nice mental health resources there. So whether they're in college, medical school, something that can also be helpful. So next questions, I'm going to direct to Dr. Kurowski and Dr. Philpott. One of my questions would be, what barriers do we see in particular for our IBD patients who are transitioning, and maybe what are some of the consequences that we see in terms of the issues with transition? So maybe Dr. Karowski, you could address that. And then for Dr. Philpott, there was a question about if we see that there may be a role for AI in terms of bridging communication between providers, patients, and family members. So Dr. Karowski, do you want to start first?
Yeah, sure, I'd be happy to. Barriers, I think it's the barriers are often easier to identify because there are red flags along the way that signal that this patient is going to need more support. And those are often your patients who, are not coming to visits. Our nurses are checking in on them. They haven't refilled their medications. They don't read their my charts, things like that. Those are patients that the barriers are going to be how motivated, what is their self-efficacy. Yes, like you can have a questionnaire, which is always nice to quantify that, but you know what I mean by the fact that they're not even going to get the questionnaire. They're never going to look at the questionnaire. That's your red flag and the barrier. So I would say a lot of that it may or may not boil down to family support, but that is another area is were they supported during those years by their family? What is their home situation? What are their financial resources? What are their social resources to navigate through these things? So this is a person who's struggling even to get through high school. We certainly see patients who go off to college and don't take off well, and that happens without a chronic disease, but it also happens with a chronic disease. The failure to launch. And so our goal is to try to identify those as much as possible ahead of time. So that is often asking, and I will just flat out ask, how is your mental health? It's something as silly a question as that is, and a lot of times that comes up when a patient may come in with a symptom, and I'm not really sure if it's inflammatory related. I have concern that, it's nausea, and then and I'll say, well, are you having any stressors? Do you think you have any symptoms of anxiety or maybe, worrying at school? And they're like, no, school, I have no stressors whatsoever. And then you start talking to them more and you're like, I think I know what's going on. I think you might have anxiety. Like, no, I couldn't possibly have anxiety. That symptom that you're having every morning where you're nauseous and you think you might throw up? That's probably anxiety. And like, it's like for some of us, it's like, how could you not, it's like, it seems so obvious, but for a patient who's never experienced that, they don't necessarily know that that's a symptom. And, so I will definitely, we spend a lot of time talking about mental health, especially after you get through those, for whether it's a new diagnosis or they had a disease exacerbation. Once you get out of that kind of more remission homeostasis period, that's where you have to go back and say, okay, we've had a lot of time that we had to talk about your body and the disease, but like, how are you doing? Not that you shouldn't be doing that along the way, but the impact that it has is huge. And you think about just like, all right, I got a 17 or 18-year-old who's a junior or senior in high school. We got to deal with their disease, and now they got to go off to college and manage that, all of that. Like, that's not fair. And unfortunately, like, but they have to. It is something that they're going to have to do, and so that is something that we have to address those barriers early and upfront. You can't plan for everything, right? Like, there are a lot of mental health issues that arise in their 20s, things that you don't ever see coming. But you try to take it one step at a time with them and get them the resources that they need.
Yeah, I certainly agree, Jake. I think those are very important points. And I find the two barriers, there's the two ends of the spectrum. There's the ones you've kind of talked about, the ones that aren't involved enough. And then there's the ones that are over involved, and the parents are over involved and overly demanding of healthcare. And those can also be very difficult transfers because the parents are used to running the show and they have specific concerns. And that, I think that takes a lot of work on those groups. I didn't anticipate an AI question for a transfer talk, but I think that's always important. So we have a question: can AI improve the communication between the care providers, the parents, and the patients? And I think, like, as is true for all AI questions, I think it's a whole new world. I think it's a tool that's really going to help us. I think we have to take care how we're using it and how we train it, because this is a very human thing. It's not very data driven, frankly. So, but I think we welcome that, just like we've been, there's this skepticism, but AI has been important for mental health care too already. So, and with that, I think we're going to move on to our case. So we talk about that. So if you'll pull up my slides, please. So next slide, please. So this is a transition visit for an 18-year-old male. He presents for transfer of care to adult gastroenterology for Crohn's. He was first diagnosed at age 14. He had weight loss, fevers, and anemia. It took a while, but eventually he had a workup, which revealed that he had extensive ileitis, some colitis, and duodenitis, the biopsies of which were diagnostic for Crohn's. And if you see in the middle, Claire, there's also an esophagus, which doesn't look too bad yet. But next slide, please. Biopsies were not taken of the esophagus. So the patient was started on prednisone and methotrexate. This was in the dark ages. His liver tests went up. It was kind of stressful to the whole family, and there's a number of things that happened, but he eventually had a liver biopsy that showed steatohepatitis. Then after some hesitation, he was started on infliximab. He was dose optimized, and he was treated with pentoxifylline for steatosis. But 2 years after diagnosis, despite being on infliximab, he continued to not feel very well. He had some difficulty maintaining weight, and his MRE was showing still 30-some years of disease and a possible stricture. So it was suggested to him that he consult with us and his family, that he consult with a surgeon with possibility of surgery for the next step. But at that point, the family decided to seek alternative healthcare solutions, and he went off therapy. So they disappeared, and they returned a year later because he was getting worse with progressive anemia, hypoalbuminemia. And he actually was started at that point on adalimumab. And at the very same time, he started a gluten-free and paleo diet, and he started to feel better. Next slide, please. So he presents to adult GI. He's been on adalimumab for a year and a half. He's doing well. He has no symptoms. His labs have actually normalized. He does have some psoriasis in his ear. And for the visit, the parents do most of the talking. The provider attempts to get the patient to speak, and when he does, he kind of echoes what his parents, their narrative. The family and the patient wanted to make sure that the adult provider understood that they didn't expect his healthcare to interfere with his school, which was he was in college at this point, that was very important to him. And then their most pressing question is they felt at this point that adalimumab was actually not necessary anymore because his improvement coincided with changing his diet, and they had some concerns about the risk of adalimumab. Next slide, please. So a couple of questions I'd like to review with my team. One, I think, Jake, you're probably best to answer this. So I think as adult providers, we're comfortable treating patients, but we're not as good as managing families. And the family dynamics can be very difficult, especially when they're first being introduced to us. And so what are some tips that you have to manage dynamics when, for instance, the parents might have some ideas about the care that might even potentially be detrimental to the care of the patient?
Yeah. And I will tell you that I have a slightly different approach depending on the age and the involvement of the patient, particularly to this case. I'm still shocked he hasn't had a surgery. Quite amazed actually that didn't happen. I thought for sure he was going to end up in the ER with a complete obstruction.
Well, I'll tell you, 10 years later, he hasn't had surgery yet. But anyway, moving on.
I mean, let's get some biopsies and gross organelles.
Yeah.
Like, I want to see how that fibrosis melted away. But for a patient who's already 18 and is really not participating in their care, that is a red flag. So, we could probably do a 3-hour discussion more on transition. There's a lot of other things, but the whole idea of transition, we really, depending on the age of diagnosis, we started bringing up 12 to 14 years of age of the whole transition of responsibility and just starting to do the basics, knowing your meds. Obviously, if you're diagnosed past that, like you'll catch up on that education. But at 18, if you're really like not independent at all of your parents, one, you're definitely not ready for transition to the adult GI side. So we have to like back up that train a little bit. Um, but two, if I have an 18-year-old who's either on their phone, not really answering questions, then one, I'm either going to ask the parents to step out so I can ask some more pertinent questions to the patient, or two, I'm going to take their phone away and I'm going to say, you are 18 and you have to be present in making these decisions. And I will be, this is where there's a balance between TLC and tough love. And if this is where a little bit of tough love comes in. And so if like we have to have a frank conversation that this is their body and their decision, and that it can't all be, you know, on their parents driving it. And then I think a lot of it is, you know, when I'm dealing with a patient that doesn't want to be on therapy, then it goes back to education. At 18, you can't make him be on therapy, obviously, right? Even at 16 or 17, you can't make somebody be on therapy. They have to be responsible to a certain degree for their own medical care. Everybody has to be on board. So it goes back to re-education of Crohn's disease. What is the natural history of the disease? What's going to happen if they're off therapy again? We already saw what happened. He already probably stricture and was lucky to get out of that. Stopping therapy again is only going to lead to another surgery. And it's quite amazing. Like I would tell him, he's very, very lucky. There is no good time in your life, particularly when you're young, to stop therapy. Like that is just a huge risk factor. So I will balance some honesty. I will balance, I feel for you. I am sorry that this has happened to you. I wish I had a cure. But I have a lot of really great options for you, and I can make you a lot better, and I can keep you well. But this is gonna be the plan moving forward, and I'm gonna give you the best medical advice that I have and the best medical care possible at this day and age. And if they're not on board with that, and if the patient is not really want to be involved, then at a certain point, right, like maybe they are going to be better served somewhere else.
And I think too, like you're hitting right on, Dr. Karowski, like this idea too, like if they dig in, like at some point it doesn't work to like push them into a corner any further. It is useful sometimes, a lot of time, in what we've done with patients, to ask them specifically, get the kiddo aside and be like, hey, what are your goals here? What are we trying to, what do you want this to look like? What are we trying to do here? Are you know, and a lot of times they'll be like, I just want to avoid surgery or something. And we can have then those discussions like, you know, about what did Dr. Karowski tell you we need to do and how do we do that? And I agree with you. Diet is absolutely a part of this and stuff.
Yeah.
What else can we do to reduce down that chance and make it so you have the best chance of being in school? Because I also heard that was really important to
Right.
you.
Right. And some patients are just like, I don't want to be on any medicine. I'm like, I can't make that happen. Like, I hear you. I would love for that to happen. I will work with you on some of these complementary things. I have plenty of patients who take some complementary alternative medicines adjunctively to their Crohn's disease therapy. And I tell them, I was like, I just don't have a world in which that exists.
Yeah, it's always
be
hard
honest.
with that thought. Yeah. Let's take the slides, please. So the patient, next slide, please. So he establishes care. He agrees to continue therapy. It turns out that the patient was actually wanted to continue the therapy, but his parents did not want him to. He at first
There
was
you go. That's where you separate, and like, I mean, that's it right there, right?
Yes. So he had been he at first would not agree to do procedures, but after a year he became comfortable with the situation and agreed to do so. He noted he actually had been having some trouble swallowing, so an EGD was done along with a colonoscopy. Next slide, please. So on the left we have the ileum, which actually was looking shockingly well histologically and endoscopically, but the esophagus doesn't look so great. So next, so we have kind of classic signs. He had actually pretty tight stricture distally. Next slide, please. So he was dilated. He returned to clinic, and actually his parents did not come with him. This was pre some of the options we have now. So diet was a no-go, and he was strongly advised to budesonide slurry, but he said, I'm just going to be honest with you, I'm not going to do this. I don't have time to mix this stuff up. I'm not going to do this. So he was prescribed with fluticasone, an inhaler, which he was to swallow and coat his esophagus. He was advised as to administration. Next slide, please. Unfortunately, soon after, within 6 months, and again, I know he should have, a standard of care would have been to repeat his EGD, but that's not something that he would adhere to. He had a meat impaction, and he returned for an EGD at that point, and his mom was there as the driver, and she says she doesn't know what he's taking, but she doesn't think he's taking his medicines the way he should be, and he's only taking the fluticasone when he's symptomatic, and she asked the provider to do something to help him. Next slide, please. So it's always tricky, I think, for all patients, but in particular for our young patients that are transferring to our care. As these patients are assuming healthcare autonomy, what are some things you do when they're not making good choices?
It's a very good question. It's, what we've discussed a lot about in terms of, getting buy-in from the patient, what their goals are, and just kind of explaining to them a little bit more about what EOE is. So, I have patients who will come to me, they've had EOE for 10 years. And I'm like, it's the first time I'm meeting you. Like, I'm sure you know all of this, but just bear with me. I want to give you my little talk about what EOE is. 9 times out of 10, the patient after that will be like, wow, no one has ever explained it to me like that before. So I think we can get really caught up sometimes in, how to treat, how to make the patient feel better, when sometimes we just need to take a step back and just, start from the beginning of, what is EOE, what things are associated with it, what are the symptoms, how do we treat it? And some of the really important things to highlight will be, symptoms don't correlate well with what your esophagus looks like, both during the endoscope and histologically, right? So I'm sure, yes, he had 3 days of chest pain, but I'm sure he felt better after you dilated him, right? And I'm sure his eosinophils were greater than 100. And he was like, great, I'm feeling better. I don't need my medication. But we know that patients will just feel better because they've been compensating for so long in terms of how narrow their esophagus is. So then when you give them some relief, they're like, great, I'm doing wonderfully, but their underlying inflammation isn't controlled. So we discussed that, and I do find that it helps a lot. And the other thing that I'll do is I never push someone, right? If they tell me like, I don't want to do anything right now, like I just can't, then I'm like, okay, like think about it. If you decide you want to start something, send me a message. Otherwise, let's have another discussion in like 2 months. And typically by that point, they'll be on board for a therapy. One of my mentors, his favorite saying was, and it's true for EOE, there's no right answer for treatment. There's so many different options that you can pick from, but he always loves to tell patients, the only wrong answer is to not do anything. You got to pick something.
That's so true. That's a great, I'm learning so many good comments today. This is a great conference. Okay, so next slide, please. So so he did start to adhere to therapy and actually did fairly well. Unfortunately, his psoriasis of his ear got very bad, and he was to the point he was a student teacher by then. He had to wear a hat all the time. Had progression of his Crohn's, so he was switched to ustekinumab. He was hesitant to change. He is kind of scarred from what had happened to him with the methotrexate, and he was also worried he would feel worse and not better. But after some discussion, he agreed. So this drug was prescribed, but unfortunately, he was having trouble paying for it. So our care coordinator called him many times. He would not pick up the phone. It was required that he call the company, then the drug company, to get on their program to get free or reduced cost therapy. And he just wasn't able to keep up with this. So at that point, he was not getting his medication. Next slide, please. So I think kind of a challenge to all of us, and we only have a few minutes to talk about this, but I think it's really something to how can we help our newly autonomous patients navigate the very expensive and time-intensive healthcare system. And I think sometimes they come to us and they're really ready to go. They're excited to be an adult patient, and then they start to get daunted with like setback after setback and problem after problem. So, Daphne, do you have some thoughts about how we can help be their cheerleader as they do become independent actors in this difficult world of being a patient?
Of course, of course. So this has to do with the self-efficacy that we talked about earlier, and something that we talk a lot about in psychology is transferable skills. So when I go into a patient's room, whether they're in the hospital or they're having a session with me outpatient, I usually ask them when they have to navigate something like that, is there another time in your life, medically or in general, where you had to navigate a situation that was challenging? 9 times out of 10, there is a situation. Having IBD, I would say, is a situation like that where they've had to persevere and find their way through it. So then we say, okay, what helped you during that experience? And are there skills from that you can use to navigate this really intimidating system? Another thing that we can do is set the SMART goals that I mentioned earlier that are specific, achievable, time focused, and all of that, because patients tend to get overwhelmed by so much information that I think all of us get overwhelmed by. And their point of reference is not the entirety of the world, but it's their peers that are probably not struggling with IBD. So they're thinking, if they don't have to do this, why do I have to navigate all of this? So I'll just throw my hands up in the air and not do it. So breaking it down into smaller achievable goals would be something like that. But mostly, I would say on a psychological level, reminding them that they're already resilient. They're, in that sense of your life is going to be challenging because of this, but you can see this as a strength that you can then use in other areas of life as well. So if you have trouble in college or graduate school or whatever it is, and you're with your kids further in life, you can use the life skills that you're learning right now, and they can help in the future as well. So again, fostering that sense of personal responsibility, self-efficacy, and breaking things to smaller achievable goals, I would say.
Well, these are definitely words to live by. Well, I can't believe that our hour and 15 minutes is over, but in fact it is. So I want to take time to thank, first of all of our participants. Thank you for listening. We had a lot of fun. I learned a lot from participating in this this Cleveland Clinic Live. And then we'd like to invite you to attend our next live from Cleveland Clinic program. That'll be on April 23rd, Obesity Management and IBD. I think this is a great field and a lot to learn. So thank you to all my great colleagues, and everyone have a nice evening or a nice morning, depending on where you're at.